All right, welcome everyone. Thank you for joining us this afternoon. My name is Erin Stagletter. I'm the Education Manager at the Virginia Breast Cancer Foundation. Today we'll be hearing from Dr. MeLanie Modjoros on the topic of sexuality and breast cancer. Dr. Modjoros is a physician and ASECT certified sex therapist. She originally practiced gynecology for several years before pivoting to a career as a sex therapist. And she founded her practice, Sexual Health Consultants, in 2014. Welcome, Dr. Modjoros. She'll be taking questions at the end of her talk, and you're welcome to enter any questions you have into the chat box and direct them to all panelists if you wanted to keep it a little bit more private, or all panelists and participants. As a reminder, we will be recording this presentation, but we will not mention names during the question and answer portion, and the chat box wouldn't be recorded. We'll also be broadcasting this on Facebook Live, but we will end the live stream after Dr. Modjoros' presentation, again, to keep the privacy of the folks who participate in the Zoom call. So with that, Dr. Modjoros, you can share your screen whenever you're ready.
Thank you. Thank you so much, Erin. Let's see, let me get the share screen thing. We always have that juggling around of technology. And share, and then it is thinking. There we go. Okay. So thank you so much for having me and inviting me to speak today on this incredibly important topic, getting your sexy back after breast cancer. And I was going to spend a moment here telling you about my story, but I don't have to, which is great. So I'm a physician and I transitioned to sex therapy, which of course begs the question, what is sex therapy? It's like regular therapy, except where we talk about sex a lot more. There's all the discussion around the emotions and the anxieties and the stressors and the expectations and the dysfunctions and the functions and the interactions. It's pretty complicated, but it's great. And then there's medical sex therapy, which is sort of my subspecialty. It's the focus on people with medical challenges. Okay, so I have a lot to cover today. Getting your sexy back after breast cancer. And this is going to be the outline of my talk. We're going to start with the sexual purpose, which is the why, and then move on to talking a little bit about sexual function and dysfunction, the what and the how, and then talk a bit about medical trauma, which is an important issue with breast cancer, then body image, and then we'll talk about creating your best sex life yet. None of this is going to be exhaustive. We're really just going to give you the glimpse of all of the factors and considerations that I go through as a medical sex therapist when I work with somebody with breast cancer. So let's start with sexual purpose, the why. So why do we have sex? Why do women have sex? Why do you have sex? Why do I have sex? We never really ask this question. We make decisions around it. I'm going to do it today, or I'm not going to do it today, or whatever. But we don't actually ever think, why am I choosing to have sex? And if you ask 3 or 10 different women that question, you will get 3 to 10 different answers. So everybody has their own answers, and there are no wrong answers. Here are 3 examples of very different perspectives on the why. So Sarah is a woman who enjoys sex with her long-term partner, and she tends to get moody when the sexual frequency falls off. And she's somebody who tends to initiate sexual play and flirtation, and she loves to tease her partner with her body. For her, sex is fun. Then there's Tanya. Tanya understands that sex is part of relationships. Her husband usually initiates, and as long as it doesn't take too long, she's pretty happy with it. He's happy, she's happy, they're all happy. And that's great. And then there's Josie. Josie considers herself a bit of a free spirit, and she expresses herself sexually easily. And she likes sex that is fun and not too committed. And so all of these women may go on to develop breast cancer. And when they do, they'll have to start to evaluate the why that they choose to have sex going forward from that point too. And many times it changes, and sometimes it doesn't. And all of that is okay. But the important part is that we ask the question. So in asking the question, I've found in my clinical experience that many times the answers fall into these 3 categories. And they're not going to be exclusive to one category. You're not going to have only one type of reason that you would have sex. But I just wanted to name these categories so that you, the viewer, can see that there are lots of reasons, and these are all good reasons. So for somebody who likes to have sex because it reinforces their connection to their partner and their relationship. They gain intimacy from sex. And sometimes they may worry about not meeting their partner's needs, but they enjoy sex, and sometimes it might be a chore, but they do enjoy the intimacy of it. And after sex, they tend to feel feminine and emotionally relieved that they've met their partner's needs. Other people may choose to have sex for the pleasure of it and the physical release. That's sort of obvious, but not always, because we assume that sex is pleasurable for everybody, but it is not always pleasurable for everybody. So in this particular case, the sexual purpose would be that the body feels better and the mood is elevated after sex. And so that's a good reason to go into that sexual experience. This type of sex can be orgasm focused, and it can feel, the person may feel an increased sense of body tension or anxiety as they, and an urgency towards sex if it's, been a while. After sex, this person may feel physically relieved and emotionally relaxed. And then there's the connection to the self and the identity. It's another good reason to have sex. This is somebody who feels whole and connected to her body in the moments of pleasure. The sex itself reaffirms her vitality, and the sex is grounding for her. And she moves towards the sex because it gives her calmness and clarity. And again, these are just 3 examples of some women's reasons to go into the sexual experience. And if you know your reasons, then you're one step ahead of the game in communicating them to your partner. Okay, so again, there's a lot more we can dive into and dig into with that, but that's what I would do in the sexual therapy session. So now let's move on to talk about sexual function and dysfunction. This is the what and the how. And clearly this is a really big topic. So we're going to talk about it from a perspective of the sex therapist. Oh, wrong way, sorry. Where did it go? Oh, okay. So sexual functions include desire, arousal, and orgasm. And just so that we're clear on the definitions, I wrote them here. The internal experience of wanting sensual or sexual contact is desire. Arousal is the sensation of excitement mixed with pleasure. It's often associated with physical signs of arousal, such as lubrication, erection, and flushing. And orgasm is the climax of pleasure and the release of body tension, and it may feel like going over a cliff or waves crashing down. It is often associated with pleasurable contractions and ejaculations. Okay, so let's talk about the sexual desire cycle. This is how desire and arousal are interrelated. And sometimes we think we can separate them. Oh, I have low desire, but my arousal is fine. But many times there's an interplay that is hard to figure out. So this is what I refer to as the sexual desire cycle. It was created by a sex therapist. I think her name is Rosemary Basson in about 20 years ago. So I cannot take credit for it, but it is brilliant. So we start at the top with emotional intimacy, and that is going to contribute to 2 people finding themselves in a situation where they want to have an affectionate moment. So somebody will reach out and touch their partner, and then there'll start to be some sexual stimuli, some kissing or something like that. And then arousal, which then leads to reactive or responsive desire, which then leads to an emotional physical satisfaction from the perfect satisfying sexual event, which increases emotional intimacy. Very simplistic in that form, but it gets a bit more complicated as it keeps going around. I'm going to go over that one more time with an actual concrete example. And for the purposes of this talk, I'm going to give you the most heteronormative, stereotypical example I can think of. So let's say a couple, the wife is doing dishes and the husband or partner notices her and says, well, that looks good to me. So he goes up and she's doing dishes, and he goes up and starts touching her backside and arms around, nuzzling her neck a little bit. So at that moment, she has a choice to make. She can choose to look towards him and turn towards him and experience a sexual stimuli, which is this moment right here, or she can choose to say, I really do need to do these dishes right now. And we all know this experience, right? We all have the opportunity to say yes or to say no. So that's what's happening here. Now let's, for a moment, assume that she turns towards her partner and they start kissing. At that point, her body is starting to respond, and she's developing, quicker heart rate, and some, flushing and other types of tingles. And those tingles are leading to her to forget about the dishes. She's just not that interested in the dishes anymore. In fact, there's not anywhere else she'd want to be than right there feeling good in that moment, because she has what we call responsive sexual desire. The arousal came first, and then the desire comes. Then they go on to have a perfectly emotionally and physically satisfying sexual event, and that increases their emotional intimacy, and that gives her, and both of them actually, the best chance to go forward through the cycle again when they get back to that, this part right here, this pink area that I'm highlighting. So please note that there is something called spontaneous sex drive in the middle, and that is referring to the sort of hormonal milieu, the balance of sexy thoughts and dreams, the stuff that comes from within, and that can jumpstart any part of this cycle, but it is not required to continue through the cycle and have completely satisfying and completely passionate and intimate sexual experiences. The idea that spontaneous sex drive must exist is actually a myth. It is not necessary for pleasurable, satisfying sex, but you do have to recognize that the choice to go into sex is a logical decision. It is not something that everybody's going to want to do just because the opportunity exists. You have to make that choice. And that choice will be relatively logical, and it will be based on the summation of the emotional and physical satisfaction and the emotions that you have after following sex from the past, and the emotional intimacy you have at that moment, most typically. But then I want to bring your attention to this area right here. This is the biological, psychological, and sociocultural factors that is where most of the work that I do concentrates. Notice how it interferes in this spot right here of the cycle between sexual stimuli and sexual arousal. The biological, psychological, and sociocultural factors refer to anything that an individual, this can be a woman or a man, but we're talking about breast cancer today. So anything that a woman identifies as a emotion or physical sensation or worry that is part of the sexual experience. So if she has pain in her body, even if it's a broken toe, that may reduce her ability to move from typically pleasurable sexual stimuli to that fully sexually aroused state. If she has a history of pain with sex, meaning last week, then, or even last month, that is also going to reduce her ability to reach her optimum arousal levels. If she has worry that she's not going to perform, worry that she's going to embarrass herself for any number of reasons, those are going to interfere with her ability to get to her optimal sexual arousal. And then sociocultural factors include the shoulds. They really refer to the shoulds. I should do this for my partner, and I should make sure that I say yes every time he asks me, and all of the, I should make sure he has an orgasm every time, things like that. Those shoulds are sort of sociocultural factors that feed into our belief system that lead us to, sometimes it can be positive in terms of sexual arousal, but in this particular case, I'm referring to those times when it interferes with the natural sexual desire and arousal cycle. So that's the concept for how the desire and the arousal are interrelated and interconnected. Now I'm going to point out that I can't name every sexual dysfunction that is common among all breast cancer patients and survivors, but here is a relatively abbreviated list and some categories that you might find resonate with you. So women with breast cancer or who have had breast cancer will sometimes struggle with fatigue and anxiety and depression, anger. They won't necessarily be able to get to their arousal state, which will then reduce their subsequent desire, which I just demonstrated how that works. They may, with medication side effects, arousal issues become a big issue, a big concern. If there is a lack of lubrication, and of course I'm saying if, but oftentimes it's when there is a lack of lubrication, sex becomes uncomfortable. And that memory of discomfort and potentially even pain with the sex is going to reduce the chances of going forward on that cycle and reduce the desire. The other thing that can happen with arousal is that with the breast cancer treatments, there can be changes in sensation. in the genitals, but also in the rest of the body, including the breasts. So those changes in sensation can include numbness, pain, tingling, which are distracting if they're like on the breast areas, or it can include reduced sensation and pleasurable ability to receive pleasure from touch from the genital area. Some women will also experience weak or absent climax and pain with orgasm, and they may struggle to relax into the moment with all of the other things that they're working on, focusing or defocusing on during the sexual experience. It's very common that our minds are racing, isn't it? Pain is its own separate category because pain can happen with any sexual experience. It can happen with arousal or orgasm. It can also happen with penetration or intercourse. It can happen when there's reduced arousal, and it can be interpreted as pain in the sexual experience when it is an undesired sensation. So in the case of numbness or tingling that's across the chest wall after a mastectomy, that may be somewhat tolerable when wearing clothes, and that you could be distracted from it. But in the sensual situation, that sensation is going to scream in the mind of how this is distracting and maybe shouldn't be there. And there can be all kinds of feelings that come up just from having that sensation that are nobody's fault. And so that describes how there can be a lot of transitions in the sexual experience in the breast cancer treatment process. Again, this is a limited list, but I just wanted to demonstrate how interrelated and overlapping all of those sexual functions and sexual dysfunctions are. And then sexual dysfunction management. Notice I said management, not treatment, because sex and sexuality is dynamic. It is something that we have to nurture and something that we have to put energy towards in order to keep it growing and healthy, like any relationship. And so, as I've shown you, sexual dysfunction is relatively complex. It's overlapping, and I can't give you specifics. You do this with this and this with this, because every woman is unique. Every woman has her own story, and often she's with a partner who is also unique and has her or his own story as well. So in terms of sexual dysfunction management, the way that I think about it is it's a three-pronged approach. The medical, you want to talk to your doctor and your medical providers about your medical options and to address any issues that are coming up relating to your sexual experience. Many times women will choose not to talk to their doctors about it, or they'll say, oh, it's just a little bit of dryness, like I will just use some lube, it'll be fine. And maybe that's the end point that she would do anyway. But talking about it with the doctor legitimizes her experience, and also honors the fact that there's a change. There's a change from her baseline. And of course there will be, but if you never talk about the change from your baseline sexual activity and your baseline sexual function, then you don't actually get to address the change that happened with the breast cancer. Sexual self and identity as a woman, or identity as a feminine person, that is very personal. Some women are able to experience breast cancer and it doesn't really shake their sense of self and their sense of sexual beingness. Other women experience a dramatic change in their ability to interact with themselves as a sexual being, their ability to see themselves as a sexual woman who may not have breasts. And that's much more tricky, and that will be in that psychological factors that interferes with the development of arousal. So it will then be a self-fulfilling prophecy that a woman who struggles with this is going to not have pleasurable sex to counteract it, the idea that she's not feminine enough. So that is something that I work with a lot of women on. And then the relationship and communication issues. Breast cancer opens up so many topics that we just don't have to talk to our partners about most of the time. And depending on the age at which you've had the breast cancer, depending on the age at which you've had other medical conditions, many times people are sort of on sexual autopilot. It's like, oh, I'm in my relationship and yeah, we have sex and this happens and that happens and it's fine. But now you throw a giant wrench into the system and you don't even know what to do next and how to even articulate the dysfunction and the challenge and the feelings and the sensations that are different, the feelings that are different, and many people will just shut down. And so whether those people are the patients or whether those people are the partners, the shutting down is a big issue because we haven't established how to communicate about the feelings well enough. And so I work with couples on that as well. Okay, but we're focusing today on getting your sexy back. So let's talk a bit about medical trauma and what that means, how I'm defining it, and understanding the effects. Okay, so I just wanted to put this picture because seriously, like this is not a breast exam, and it's almost comical that it would be depicting one because there's so many things wrong with this photo, but at the very least, breast exams do not happen through sweaters. They just don't. And so in this topic, I'm going to talk about what medical trauma is. It is not, in my opinion, from a sex therapist perspective, it is not a negligence. It is not an abnormality of medical treatment. It is not anything nefarious like that. It is, it is the experience a woman has going through treatment and survivorship with her breasts and her body. So every woman prior to diagnosis has some sort of relationship with her breasts. That relationship may be positive, it may be neutral, it may be that she's annoyed by them because they're too large or too small. It may be that she's happy with them because her partner is happy with them. It may be any number of types of feelings that she associates with her breasts. Most women experience a sense of safety with them in that they're part of their body that's relatively dependable. They're sort of always there. So there's a consistency, and we don't usually think about our relationship with our breasts, but we have one. We all have one before the diagnosis of breast cancer. And once we get breast cancer, that relationship changes, and it changes in important ways, but it does not change in predictable ways for any particular woman. So part of the medical trauma that I'm referencing is how breasts, for most women, are an area of their body that is associated with intimacy and pleasure and arousal and vulnerability, and more of a specific person or persons who get to view, see, or touch those breast areas. And then you become a patient where everybody is touching your breast area, everybody's looking at it, they're talking about it. There's an incredible amount of conversation and evaluation of the breasts themselves, which then doesn't feel congruent with your previous experience with your breasts. And so the diagnosis and prognosis has a lot of components in that brief section of all of this journey. Oh yeah, so this mammogram, no woman is this excited to have a mammogram. I'm just going to say that. So as I said, the sensual becomes clinical and it becomes scary. Real patients are not this excited. Breasts become on display for everybody to evaluate and discuss. Legitimately, everybody, right? The medical team members. And then invasive tests and procedures actually introduce pain to the breast area, which is exactly opposite of the breast's identity as a pleasure center. So that's a bit of a conflict, internal sort of discord with what that feels like for a lot of women. And then during treatment decisions and surgery, radiation, and chemotherapy, there's so many decisions to make. Breast exams, lumpectomy versus mastectomy, single versus double, nipple sparing, all of the symptoms that happen with the treatments, nausea, weakness, loss of hair, again, worrying about the future, that one never seems to go away. This is an intense phase of breast cancer treatment, of the breast cancer journey. And sometimes in this phase, sexuality and sexual experiences are the farthest from a woman's mind. Other times, sexuality and the desire for sexual experiences is high in her awareness. Even if she doesn't feel well enough to be involved with sex, she really wants the connection. She really wants the touch and the intimacy. And every woman is different. But the important part is that we name it, acknowledge it, and ask about it. The relationship with the breast during this phase can become pretty adversarial. The breasts may become internally seen as the enemy. So no, a woman may not say, oh, I hate that I have breasts, or my breasts are my enemy. But the change of feelings towards them, that I have to take this chemotherapy because I have something wrong in my breast, and it's a disease. It's the big C. And there's all kinds of feelings that develop from this treatment phase, within this treatment phase, grief and anger. And that may cause a woman to lash out at loved ones, but it also may cause her to actually withdraw from relationships that are very, very important to her. And this is a huge time when grief first hits most women. Oh, I went too far. Okay, recovery, reconstruction, and follow-up. So again, more breast exams. You see that there's a theme here. Adjusting to the new body, mourning the losses, discomfort at incision sites, medication side effects that remind you that you always had breast disease, and that perhaps you will again if depending on your treatment plans. The touch and sex may actually be uncomfortable and anxiety provoking and triggering. And then of course there's worrying about the future. So, the recovery phase, I don't have an extra slide for that one, but that one is just difficult because the new normal, nobody tells you what the new normal is going to be. And you're on your own to try to figure it out. What is the new sexual normal for you with the history of your sexual purpose and the history of your sexual breast cancer treatment and all of the interactions that you had with your partner during that entire experience? What is the new normal for you, and how are you supposed to figure that out? It's really, really challenging, and I don't think that breast cancer patients get enough guidance in that direction, or their partners, because again, many times we're talking about the couple. So one of the most common talked about issues around that new normal is the body image, which I've nicknamed the naked truth. So body image is not just what you think about your body, it is also sensation and emotion associated with the body and how you process those. So a woman may experience the missing of the previous appearance or the previous function of one or both breasts. And this is an interesting idea. It's not just, one type of treatment that results in body image issues. If a woman has mastectomy and reconstruction, she has one breast that has normal, pleasurable sensation and the other one that doesn't, her past memories of sex include bilateral breast stimulation, perhaps, right? Touching both sides at the same time. Now, that may still happen with her partner, but instead she only feels one side. And how does that feel to her in that moment? That's the type of experience that can feed back onto body image. Another example would be if a breast cancer patient experienced radiation across the chest and the skin changes as a result of the radiation therapy. And then again, similar types of discordant experience of I'm expecting to have both breasts feel like breasts, but in fact one doesn't anymore. And the partner can experience this as well. All of that just feeds back into stress and anxiety around the sexual experience. So these women will, and their partners, will worry about being attractive and appealing to their partner. They will worry about their own sexual experience. Will there be pain? Will there be embarrassment? They will worry about their partner's sexual experience. Will they be good enough? Will they be pleased with them? Especially if the breasts were a significant part of the sex before the cancer. And then there's the sadness when the breast or the chest is exposed. And, that's going to fade and get less and less as the new normal gets more established. But I don't want to forget to name that. We have to acknowledge that if there is a sense of loss with the breasts, there is also a sense of sadness when exposing them that often accompanies that. If there's a sense of gain after breast cancer, so that would be if you ended up getting a reconstruction that you were really, really happy about, which also happens, then maybe there's a sense of pride. That's all still body image. It may not be a body image negative issue, but it's still body image. And so the goal is to move through, I don't know if you guys can see it. I don't know if my face is covering it, but moving through the recovery, almost like a second adolescence. So the goal is to reconnect to your body and to your breast appearance and figure out how to make them yours again. Those breasts were yours once, and then they had to be sort of loaned, temporarily to the medical establishment to get you healthy or keep you healthy. But now they're back to yours. Whether it's a chest that you don't have reconstruction on, it's still yours. Whether it's a reconstructed breast, or whether it's breasts that just have been changed with lumpectomy or any other more minor procedures, they're yours again. And for you to start to own that and associate into that is part of the recovery. And in that recovery, you get to redefine and recreate your pleasure in your body, allowing the feminine energy to flow. And those are fancy words, you put them together and they sound nice. But in reality, that's actually what has to happen. You have to get to a point where you can say, you know what, that was part of my history, and that is bringing me to now, right? Breast cancer will always be a part of my life, but it doesn't have to be a part of this moment. Because in this moment, my body's job is to bring me pleasure. That's why it's here. That's why I'm here. And then the emotion that flows is good too. I just love these pictures. These women look so happy, honestly. They've figured it out. They've moved through that recovery and they've got the twinkle. Okay, so again, moving forward, creating your best sex life yet. Okay, so there's, I can't tell any particular woman how she can best move forward, but I do have some guidelines that I recommend going through, and at least sort of going through that process so that you are on track and not missing anything. And so one, you may have guessed, is to establish and identify the purpose that you want to have sex. There is no wrong answer. The reason that you want to have sex now, post breast cancer, may be completely different than the reason that you chose to have sex before breast cancer. Sex can be defined by you. It does not need to be defined by society or by your partner or by anybody else. And so your sexual purpose should be established in your own awareness, because when you have that sexual purpose, then the feminine energy and the flow happens much easier. Address sexual functions and dysfunctions. That's what it says behind my face. Body image and connection to the body pleasure. That's something that we just touched upon, and we'll talk about it again in a minute. And then explore and discover, because it's a whole new world. It's very exciting. Okay, so this is just a recap of sexual purposes. Checking in with yourself. Why do you want to have sex now? What do you want from it? When you're done with the sex, what will you have gained? What will have changed in your moment daily life right now? Perhaps you will be feeling connected to your partner. Perhaps you'll be feeling more relaxed and physically relieved and emotionally relaxed. Or perhaps you'll be feeling more vital and calm and more clarity. Or perhaps there's another category or another purpose or goal that you have for the sexual activity. And all of that is completely fine. What's really great is to tell your partner what your purposes are. And if they tell you their purposes back, you may be surprised depending on how articulate they are. This is a hard one. Everybody, if your partner's male, everybody expects men to have a single and solitary reason for having sex. Our cultural norm is that men have sex because it feels good to them and they always want to have sex. It's really not true that way. Many of them have, most if you were to ask me, but have an incredible connection to their emotional health and to their partner through the sexual experience. So I don't want to ignore that or negate that, and giving your partner the opportunity to tell you why they want to have sex with you may open your eyes to other reasons that you didn't assume to start with. But same vice versa, they would love to hear why you want to have sex with them. Even if you don't want to have sex right now, even if the vagina is hurting or there's some sort of not right now, honey, kind of a thing, telling them why you do want to have sex with them, even if it's not wanting it right now, that's the important thing. Sexual functions. So sensation and arousal. This is something that I recommend that you discuss with your breast cancer team to manage the hormone balance as needed. Not everybody who has breast cancer has hormonal treatments and anti-hormonal treatments, but for those patients who do have anti-estrogen or aromatase inhibitors, there are many non-hormonal treatments for vaginal dryness that are available. And there's also a lot of your team members, your medical oncology team, is going to be the ones who know the most recent research on the safety of all of the all of the possibilities. So that's who you're going to want to actually talk to about it for the medical side of it. For the desire part of it, if you can get the arousal and the sensation figured out, then the desire may follow very easily. Or if it doesn't, you can discuss that with your medical team and consider a sex therapist if you need that help. In general, you can also work on mindfulness and meditation through any of those, commercially available apps that sort of train you to do mindfulness. That's an excellent way to sort of get more in the moment, but it's not always an easy journey. And remember that sex is for you. It's not for anybody else. And your body is there to please and pleasure you, not anybody else. And so rediscovering your sexy. Let's see if I can move this. I don't know if it's in the way for you guys, but rediscovering your sexy is acceptance of the changes that happened that you did not expect. We are all going to have changes that happen that we did not expect. And in breast cancer, that is one of those things that sneaks up on you. You make a decision to do some sort of treatment plan, and you know it's a good decision, and you've prepared for that decision, but when it comes right down to it, the results of that decision are really hard to manage emotionally. So acceptance of that is a process. It will not happen in a day, but knowing that you're working towards that and having a goal of acceptance is a good strategy. Openness to finding new ways to feel good. Just because your sexual script included A to B to C to D in the past does not mean that it has to include any of those things or in any specific order going forward. You get to decide yourself what it is that feels good to you in the now and then in the then. And then connect to yourself and your partner in new ways. You can become embodied and sexually empowered. So in this survivorship phase, this is your chapter. This is exciting that you get to explore and discover. And if you look at it from a perspective of what does it feel like, instead of what doesn't it feel like, that's going to give you a much more curious and pleasure-based perspective. Oh, what happened there? Okay. And so the next thing that I recommend for rediscovering your sexy is to release limiting beliefs about how and what sex should be. The word should is like possibly one of the worst words in our language. And so when you think about what you have feelings about, I'm sad that this, if you can get yourself down to a should statement, why am I sad about this? Well, I'm sad about this because I should have this instead. Then you can start to evaluate, is that should statement a limiting belief or not? Engage your breast cancer. I mean, I've said this before, but it's still good advice. Engage your breast cancer team members for help and guidance. We can help. And breast cancer will not always be a part of your life, or will always be a part of your life, but it will not always be a part of your sex life. And these women, they really embody the sexy fun that can happen at any age and with any hormonal balance. It is flirtatious. There are inside jokes, the twinkle in the eyes, the promise of pleasure, because there's been a bit of a history of pleasure because these women have gone through and actually explored their new normal, found it for them, and now they flirt with their partners in really fun and exciting and passionate ways. And I know that I put this on the other side, but I feel like it's just so important. Breast cancer will always be a part of your life, but it will not always be a part of your sex life. And so, in summary, get your sexy back after breast cancer. Consider your purpose in having sex. Reconnect to your body and your pleasure. Communication with yourself and with your partner, and get help to get your sexy back if you need it. And I actually have a long list of resources that I can get for you, but I just didn't have time or room to go into them today. So you do have available to you a free breast cancer resource guide, and it's at this. You can get it at this at this website, and also I think that Virginia Breast Cancer Foundation will send that out as well, hopefully. So that concludes my talk.
Well, thank you so much, Dr. Modjoros. Really appreciate your time. We do have a couple of questions. And if any of you all watching this would like to submit any questions, you can do so either through the Q&A or the chat box, where I'm watching both. So first question, you mentioned, communicating with your breast cancer team. One question we had was, so how does someone with HER2 positive on estrogen blocker get back to having adequate vaginal moisture and external reaction with natural medicine or other solutions? So is that something that someone should communicate with their specific physicians?
So that is beyond the scope of my knowledge base at this moment in time, because those research things, the treatments for the vaginal dryness and irritation that follow as a side effect from those medications is a rapidly developing field. So you do want to speak to those doctors who are treating breast cancer and are up to date with the most recent studies. For example, there's the energy devices that are designed to put energy into, through a sort of device that they use energy. I'm not going to say their names or anything like that, but lasers and things like that are used in breast cancer patients to rejuvenate. I don't like that word either, but basically plump up and sort of remoisturize the vaginal canal. And, the doctors who do that type of work will be the best resources to answer that question of whether that's appropriate for you. And you have to consider all of the factors, because that's not a one-time treatment. It is a sort of intermittent, usually you have to go back and follow up with it. The other, there are a lot of non-hormonal treatments that are available. There are a lot of hormonal treatments that are also have been shown. There are lots of studies that show certain types of hormonal treatments may be safe, but that's not across the board. That is something you do really need to talk to your oncologist and your whole team about. My role is to work on the emotional component of the recovery process as a sex therapist. And so from that perspective, I would encourage you to reduce anxiety by getting more information, by asking everybody, which is great that you already asked me, but keep asking your team members, because breast cancer has a lot of people involved in the team. It's a big collaborative project. And so you're not going to be limited to only one doctor's opinion. You will have more than one, usually. Even if you go to your primary care doctor, your gynecologist, your breast cancer doctor, your oncologist, all of those, your surgical oncologist, like everybody kind of has some knowledge of it if they're directly treating the cancer.
So another question I have, because a lot of this is about communication.
Yes.
So do you have any guidance as to either how someone can start a conversation with their doctor about this issue, or guidance on how to start the conversation with their partner? Because I do think that this can be an uncomfortable topic for some people, and if there's a little bit of guidance on how to have that conversation, I think maybe people will be more comfortable having it.
So it's going to depend on the personalities of everybody involved. When it comes right down to it, you'll have to make a game day decision about how to approach your doctor, depending on how warm and open your doctor is, and same with your partner. What I recommend is know what your purpose is going into the conversation. And so one of the ways that I've seen patients sort of struggle through this and not get what they really needed was for them to sort of open a topic, but not actually ever close it. So that, let's say they go into their breast cancer doctor's office and they sort of like, okay, so, have you noticed any changes in your breasts? No. Okay. Well, and do you need refills on your medication? Well, yeah. I don't know. I don't know. Sex is kind of, I don't know. It's a little uncomfortable. Is that okay? And then the doctor says, yeah, you're on this medicine. That would be expected. And then that's it, right? You didn't get to close that conversation. You didn't get to really name your concern and your need. And the need at that moment in time is that you wanted, number one, validation that it is an important issue because you went through the effort to bring it up. And two, that you actually would like to know if there are treatment options available. And if you find out that there are a bunch of treatment options and you choose none of them, that is okay, because you have still gained the valuable information that there is something out there if at some point you want to change your mind. So, even if you're in the I'm never going to take estrogen camp, or I'm not going to do this, or I'm not going to do that, all of that is okay. Gaining the information is going to give you more power and control over your own health and body. And so that would be one thing I would definitely recommend for doctors for conversations or with doctors, because doctors tend to be rushed and everybody wants to do a good job by their patients, but sometimes it's easy to, get distracted from what they might be trying to say. So the clearer you can say it, maybe writing it down can help. Write down your questions and see what the endpoint you want from asking that question is. And then in a similar way, for partners and discussing these delicate topics with partners, it somewhat depends on how your partner likes to be approached. Some partners don't like to have a big, heavy conversation hanging over them in the future, as they'll become anxious, perhaps. So if you say to them, I have something important I want to talk to you about sex tomorrow, they're really dreading it for the next 48 hours. That's not ideal. But you would have to know your partner for that. Actually, I'm developing a course, 6-week Get Your Sexy Back After Breast Cancer course, and it's going to be available in November. And and included in that course will be a worksheet on sort of like it's an actual worksheet. So you actually work through the worksheet with your partner in sort of how to discuss pleasure issues and issues around comfort and pain, discomfort, pleasure, sensation within the sexual experience. It is very hard to talk about it, and you don't know how your partner is going to respond. And so that's what sex therapists can help too. But the simple stuff is simple, but when it gets a little bit more detailed about this position made this happen, and then I felt this way, it can get very complicated very quickly. And we know that it does, and that's why most people avoid talking about it.
So another question is, we have heard throughout the years that this is definitely that patients and survivors want to get more information about sexual health during and after breast cancer,
Right.
but may not be aware of how to find a sex therapist, what you do in a sex therapy session, does insurance cover it? Those kinds of questions. Can you walk us through that process a little bit in case anyone might be interested?
Absolutely. So I, as I mentioned, or I think Erin, you mentioned it, I am ASECT certified sexuality counselor. ASECT stands for the American Association of Sexuality Educators, Counselors, and Therapists, which is why it's abbreviated. And so ASECT is an organization that is very sex positive and progressive, and they have very stringent requirements in order to become certified. You have to do a lot of hours of study, as well as supervision, as well as a bunch of other things. And so when you go to somebody who is ASECT certified, that means that they've really put in a lot of time and energy to learn the sexual counseling art. That is, I believe it's ASECT, AASECT.org. I believe so. But it is also on my breast cancer resource list. It's like a 3-page list. So it includes books and includes websites, and it includes my sex therapy resources such as ASECT, and also my website, which is sexualhealthconsultants.com, which is listed there too. And so that's a good place to start. You can also go to Psychology Today. I don't have any affiliation with them. I mean, they're a marketing group that is affordable. So most therapists who are sort of solo practitioners will put their information on there, and you can search on Psychology Today for sex therapy. And so if anybody clicked that they do sex therapy, even if they're not certified, they will show up in your list that way based on insurance that they take. And you can search for that, and you can also search for location, insurance, and other types of factors, and things that you're looking for. The insurance question is a tough one because mental health, generally speaking, has very poor reimbursement with the insurance industries. So most sex therapists don't take insurance, as far as I know, but there are some that do. And that's one of the reasons that I made this 6-week course. It's a mini course because I can't do everything in 6 weeks, but I can get you a good start. And that's because I really wanted to give people who have these common challenges some resources that are really meaty resources with lesson plans and audio meditations and all of the other worksheets and things I'm including, that I wanted to give you them at an affordable price point, so that it wasn't an issue of accessibility as much to get the sex therapy help that you need.
Thanks. And so what can you, so we have a guide in our survivorship packet talking about what to expect when you meet with a typical mental health therapist, you know, things about informed consent and things like that. A little bit about what the intake appointment looks like. Could you give some general information as to what that would look like with a practice like yours?
Yeah, I can. I'm not sure that it would be as standard as everybody else's, but I can. So I will see individuals or couples, and so it varies slightly what I do the first visit. I'm somebody who, I don't actually like all of the forms that people fill out ahead of time. So I just say, you know what, I'm just going to take the 5 minutes in the first session to get to know people so that we can actually get to know each other a little bit. So I actually don't even get their, their demographic information without being in front of them, or on Zoom as it is these days. So remember, and I see a clientele that has a lot of medical conditions, and I am a medical doctor who I used to do women's health and gynecology. So it is important to me to know what exactly their medical issues are. So I will see somebody, welcome them, tell them a bit about myself because I have an unusual background, and then I'll ask them some boring demographic questions, sort of age and phone number, email address, things like that. And then I will ask them, and I'm taking notes on it the whole time, and then I'm asking them more like medical history questions. And after I get through their medical history and their medications, then I ask, what brings you in today? Now, some other sex therapists may choose to go into more detail with how have you been in counseling? What were your parents like? Did you have, what was your first sexual experience like? I tend not to be very invasive like that. It's certainly not at the beginning, because I think it'll all come out when it does, because I want somebody to tell me in their words what their challenges are. And once they tell me in their free form that their challenges, and I might be taking notes, then I start to ask some sort of guiding questions, and I do check in on their sort of emotional safety within their relationship, and also their history with their own sexuality in terms of solo play or masturbation. And then I get more into the details about what their sexual experience is like right now with their partner, perhaps, or even by themselves. What is it, the detail? And so at that point, I do get into detail, literally, as if I'm a fly on the wall. And remember, we know each other already for like an hour at this point. So, sort of like, okay, so what happens and how do you find out you're going to have sex? When do you know that that's on somebody's mind? When is it on your mind? How do you initiate? What is said? What do you feel when that happens? Where does it happen? What are you wearing? Who takes off the clothes? Is it you taking them off? Do you just, there's all of these things that really set the scene for the mood and the experience and the emotional warmth around a sexual experience. And so when I ask those specific questions, I'm getting a feel for the experience that they're having, which gives me better information that I can work with the treatment that I do with them. And then I give them homework. Many times it's reading, and my reading list that I recommend to most people is on the resource guide. If you'd like it, you can go and get that. And then, so some of it is reading, some of it is touch exercises that are very, very specific and very structured, because the issue about touch and sex is you have to create safety. And if safety has been removed from the situation because of any of the issues maybe we've already talked about tonight, then you have to recreate the safety and know that whatever is bothering the person is taken off the table. And so then I do those types of exercises with the couples. I tell them about them, and then they go home and do them. And then in 2 or 3 weeks, I have them come back and we talk about how it went. And that's where they learn how to communicate about their experiences with each other.
Thank you for that. I think that can be helpful in demystifying the experience, because some people, they might feel nervous going to any kind of therapist and then going to a sex therapist, like, oh, I don't even know what it's going to look like. So this way there's a bit more information. So if they're interested in maybe going down that route, they have a bit more of an idea of what to maybe expect.
Yes, absolutely.
Well, at this point, we don't have any more questions. So Dr. Modjoros, again, thank you so much for your time. We really appreciate it. And we will be working to get that link to the resource guide that you've created on the email that we'll be sending out to participants tomorrow. And if for some reason we can't do that, then we'll include it on the page with the recording of this webinar. So thank you all for joining us this afternoon, and have a good rest of your week.
Thank you too. Good night.
Thanks. Bye.